Keegan, you're there.
Yes, I'm here. I'll call the rest to log in now. Yeah.
Okay, sure. So I think maybe before they come in, I'll just try to see whether they can share content. Huh?
Okay.
The internet doesn't work so well in the office, unfortunately. Okay. You won't be able to see me, but that's okay. Okay, so you can see the screen now, I'm sure.
Yes, I can see the screen.
And right now?
Yep.
Yeah, okay, good. Okay, so never mind, it's okay. We'll just wait for them to join in. One thing we can do while waiting is try to mute the participants. Mute all so that we don't distract people, right?
Yes.
Okay, so I'm going to mute off. If there's any problem, you call me directly on my number.
Okay, sure.
So that I know what's happening, because there was one or two tutorials where I gave a lecture for 45 minutes and then nobody was listening at the end. Okay, I think Ian, if you can't hear me, you'll call me, right? Yeah. And then what will happen is at 12:15 sharp, I'll start, because I know you guys are also very busy. So we won't try to waste anybody's time, because the numbers are becoming like back to normal sort of numbers, right? So we are aware of the workload. So, and Dr. Tang, Waisan, hey, she was here. How come she disappeared? She's good. She has to go home and sleep. Okay, she's on call. She was on call. Okay. Okay, so I'm going to start now by giving a quick introduction. Now, the links that I sent through Keegan, for some reason, they've got disrupted. So over the weekend, I will try to create new links for you guys. But the whole purpose of this is, I'm sure many of you who have been in the posting for the last 2-3 weeks already, you realize that things are getting a bit painful. There are a lot of patients who are coming in with very non-specific complaints of various sorts, headache, dizziness, that kind of thing, right? So I'm just going to spend maximum 45 minutes, but probably by 30 minutes, I just want to finish today's tutorial, just to give you an overview that one of the things that's underrated in clinical medicine is that, you know, if I give you this formula 2 + 2, all of you know the answer is 4, right? Straight away. And it was involuntary thinking, meaning that even when some of you who are half asleep, the answer just shot into your head. Okay, but if I were to give you a problem like this, you realize that firstly, the answer is not forthcoming, right? It's not self-evident. What you need is a formula, right? Now, with this formula, you work through step by step, right? So, although you don't know how to solve this big problem, you don't know what the answer is, but you know how to solve this and this, correct? 5 × 5 is 25. Then you carry forward. 4 × 5 is 20, 22. Then you carry forward, correct? Each step, you know how to do. Okay, each step you know how to do, and each of these steps are easy to do within anybody's expertise. You don't need to be a very sophisticated person for that. And before you know it, okay, you follow step by step, you'll get the final answer for this. Okay, so this is the basis of clinical medicine. Actually, most of clinical medicine requires you to use a formula like this, a formula. But the problem is our part of the brain that is lazy and that doesn't require any effort or energy, which is the 2 + 2 part of the brain, okay, comes in and tells us this is the answer. Okay, so this is not useful for most clinical medicine. Maybe if you are a super experienced clinician, you know, you can just smell the diagnosis, yes, but it's terribly overrated, to be honest with you. Most people require to use a formula like this. So I'm going to just, because over the next few weeks, as the patient load is increasing, you're seeing a lot of patients with a lot of bizarre problems. What you need are formulas to quickly solve these problems. So today's lecture is going to be not a lecture. I just want to introduce the key formulas. Introduce only. And like all formulas, you don't need to really learn in depth. You know the formulas, know where to look for them and apply it to them. Okay. Now, some of you who are a little bit more curious about these kind of things, you can read a little bit about what I just talked about in this book. Okay, but this is not the only book that talks about it. The so-called fast thinking and slow thinking, the one that requires you to come up with the answer 2 + 2 very quickly, and the slow thinking that requires energy and effort, and that's less errorful. So clinical medicine is this. Okay, so I'm sure you've been tormented, okay, and I use the word tormented on purpose, by many patients who come and tell you that they have headache, correct? So, and sometimes the way we approach headache is based on this. This is a real scenario. It's a patient that a few months ago, me and my MO, we went down to the emergency department to clerk patients. And then this was the story that was given to us. Okay. So when you look at it, the 2 + 2 part of your brain says nothing is wrong, right? Right? This sounds very unremarkable. And the gut feeling that you get, the so-called, the intuitive judgment, oh yeah, this is just minor headache. She looks well. Let's send her home. And that's what's written in written in the ED notes. Looks well, observe and discharge, that kind of thing. But then we applied the formula, and later we'll go through the formula, and we discovered that actually, where's the thing? Oops. She actually had a bit more history. Okay. This part of the history was messed up. Okay. Now you realize that with this background history here, you realize that this lady's headaches could be a number of things. Correct? Now, of course, it doesn't mean that just because she has this means every time she got a headache, it must be a serious problem. On the other hand, the fact that she has this means that you have to take this piece of information with a little bit more depth than you originally did, right? So that's the basis of the formula. Okay, so let's quickly go through the headache formula. Okay, I'm just going to introduce it to you today. The headache formula is based on 3 questions. Okay, 3 questions to reduce your headaches. Okay, I can promise you, and I think Sichi and Wai-san can testify that every time we see a headache, we apply this religiously. Okay, I use the word religiously very loosely. And then we quickly come to a solution and then move on. Okay, so what are the 3 questions? First of all, ask yourself, does the patient story fit into a primary headache diagnosis? Primary headache means the patient has got recurrent benign headache syndrome like migraine. Okay, an analogy I always use is that if you see an asthmatic wheezing, you're not so alarmed because you know this patient is asthmatic, so he's entitled to wheeze. But if you see a 50-year-old person who's never got anything in the past to suggest asthma, and then suddenly comes in front of you and starts wheezing, then you have to start thinking about all these bad disorders like airway obstruction, cancer of the lung, and all these things, right? So the way you approach the patient straight away changes if you don't have a primary headache syndrome. So primary headache syndrome means that the patient has, no matter how much he's suffering, he's got a benign disorder that makes him have recurrent headaches. Maybe some kind of sin he has committed in the past life or so, but he gets recurrent headaches for no reason. Okay, the recurrent headaches can be migraine, can be tension headache, can be cluster headaches, can be any of these syndromes. Okay, and so how can we find out what these syndromes are? Well, there's this beautiful website. Okay, if you just click on it, it gives you beautiful features. Okay, just like this is a zebra. How do you know this is a zebra? Because somebody had taught you in the past that it's got 4 legs and it must black and white stripes, right? So the same way, this classification will tell you why is a patient headache considered migraine? Why is a certain headache considered tension type? What are autonomic cephalalgias like cluster? What does trigeminal neuralgia sound like? Okay, so quickly look it up. You don't need to memorize it, just look it up. Okay, so whenever a patient comes to you, find out what is his background in terms of what is the background headache that the patient had in the past. Okay, then the next question you need to ask, okay, is there something in the patient's story that suggests that he has something more sinister than his usual primary headache? So that means this is what we call a red flag. Here I need to explain a little bit. Now, primary headache means that the patient has got recurrent pain, but the pain is not due to anything sinister, it's just recurrent. Okay. What red flags means that the headache is a symptom. It is a symptom, meaning that means to solve the problem, you need to find out the underlying cause. So this is where the problem comes with a lot of doctors, a lot of us, because nowhere in medicine do we see a symptom. Sometimes it's a symptom, but sometimes it's a disease. So you realize headache is sometimes a disease when it's migraine. It's a disease on its own, but sometimes it's also a symptom. When it's a symptom, then it behooves you to go and look for the underlying cause and treat it, because otherwise you're going to miss the underlying problem. So the irony is, pain is an alarm system, correct? So when you have abdominal pain, you have back pain, you have wrist pain, you have eye pain, most of the time this pain is is a symptom due to something going on in the body. So usually no problem, you just go and look for it. But for headache, unfortunately, it can be a disease, which is this, okay? Or it could be a symptom. So how will you know it's a symptom? Well, very simple. You have a checklist of 5 questions to ask. Just go through the checklist. Just like a pilot going through a checklist before he takes off. Just quickly ask, Madam, your headache, is it associated with weakness, numbness of the body, slurring of the speech, double vision? Okay, any of these symptoms are present, then it's a symptom. Okay, is your headache associated with obtundation of sensorium? Straight away, that means it's a red flag. Is the symptom, is your headache associated with symptoms of raised pressure, like profuse vomiting, headaches worse on lying down, things of the sort? Do you have symptoms suggestive of headache? Symptoms suggestive, the headache, is it associated with symptoms suggestive of meningitis? Doctor, my headache today is associated with fever, I've got rash on the body, my neck is very stiff, and I'm feeling miserable. Okay, so that is meningitis. Then finally, the group number 5 is a bit difficult because it's not just one question, it's many, many questions. These are characters of headaches that are unusual in primary headache. Okay, for example, thunderclap. Thunderclap means the moment it started, it reached its 10 out of 10. That means at 0.0, it's 0 out of 10. 0.1 millisecond, it becomes 10 out of 10. That is thunderclap. Okay. So when you get the thunderclap headache, that's very unusual for primary headaches to have thunderclap. Now, many of you who are listening to me have migraine. So you know migraine doesn't come like this. It builds up a little bit, and then builds up, right? So when you get a thunderclap headache, you have to think about sinister causes like subarachnoid hemorrhage, cerebrovenous thrombosis, and things of that sort. Primary headaches usually don't wake you up from the sleep. So again, nocturnal headache. Primary headaches never start in an elderly patient. They could start when he's 16 or 17 years old. By the time he's 70 years old, he can come and see you and says, Doctor, I've got headaches for the last 20 years, 30 years. Yes. But if you start having headaches at the age of 70 or 80, it's likely to be a secondary headache. Okay. So please be careful. Okay. Then the last question is the patient profile. Patient profile, it contextualizes the patient to these 2 conditions. Now, rather than just explain in theory, I'm just going to go back to our scenario earlier and go straight to that patient that we met earlier. Okay, so then you'll understand what I mean. But basically, this is the summary of what we discussed. Okay, 3 buckets of questions you need to ask. Okay, ask what is the background pre-morbid headache syndrome that the patient has. Secondly, what are the 5 red flags, and have we gone through the 5 red flags? Then find out about the patient's comorbidities. You put all these 3 together and throw it into the black box. Okay. At the end of the black box, then you decide, inside the black box, you decide, what am I going to do with this headache? What is the index of suspicion for secondary headaches, and what investigation do I need? Okay. Now, so we'll go back to our original patient and then we'll discuss the thing again. So where am I? Let me see. Yes. Okay. So this was the lady, right? So we went to Clark. My MO and I went to Clark. Okay. We said, okay, the emergency department has written a lot of things in the notes, but let's apply our formula. So we asked her. She's a 21-year-old lady. And she told us, yes, doctor, I've got headaches for the last 2 to 3 years. And episodic, it usually lasts 3 to 4 hours. When it comes, it builds up over a period of time. It's got a throbbing nature to it. When it comes, I feel really a bit of motion sickness, a bit of dizziness, feel nauseated. Sometimes I actually vomit. When I vomit, I feel better. Whenever I have the headache, I just need to go and sleep. If I sleep, if people let me go and sleep in a dark room, quiet room, I'm fine in a few hours' time. I don't even have to take painkillers. So we said, oh, this lady does indeed have, does indeed have headaches characteristic of migraine. So that was the first question we answered. Okay. Remember this, the girl that we saw in ED. So for those of you who came in a bit late. Okay. Then we said, let's apply the 5 red flags. So we asked her, madam, do you have any weakness, numbness of the body? She said, no. Do you have slurring of speech? No. Do you have any double vision? No. Notice it's a checklist also. You go through the cranial nerve and the long tracts. So checklist. And then she said nothing. Then we said, okay, what's the next in the checklist? Obtundation of sensoria. So we said, did you lose consciousness or anything? Then the lady, this was a 21, she's 21 actually, 21-year-old lady, right? So she was a little bit a moody sort of person, a little bit of a teenager sort of person. So she wasn't really forthcoming. And she was just lying in that crowded emergency department trolley. And so she just looked away. At that time, the mother, who was standing maybe 2 or 3 beds away, heard us asking about obtundation of sensoria. And she quickly came and said, doctor, actually, now that you asked this, we didn't say this earlier on because nobody asked, but now that you asked, yesterday at the onset of headache, my husband and I heard a sound in a room. So we walked into the room and we found her on the floor. And we realized that she had fainted. And then after waking up from the faint, then she complained of headache. So we said, oh my God, my MO and I looked at each other and said, oh, thank goodness we were going through this list. Okay, because without the checklist, we would have missed this symptom, right? And the patient wouldn't even have volunteered the information. So we were happy that we got this information. Okay, then we went through the next question. Do you have vomiting? No. Do you have any blurring of vision? No. Does the headache get worse or lying down? No. Then the next thing we asked was any constitutional symptoms. Then there was no temperature documented in the emergency department, but again, there's a typo here. It's 37.6. When we asked the mother actually said, yeah, actually yesterday she had a low-grade fever. Okay, because of she was feeling a bit warm. I took the thermometer and measured it, and it was 37.6. So low-grade temperature, and she was very lethargic the whole day. She was sleeping in the room, and she didn't want to go to work or anything like that. So we say, hey, something is going on. So question number 2 and question number 4 worried us. Then the next question was character of headache. And then we realized that although the patient wasn't willing to give the story now, the mother said, actually, doctor, yesterday the headache was much worse than I've ever experienced. I've ever seen her experience. In the usual migraine, she's not like that. So change in character. Change in character is not really a definite red flag, but it is something to take note of, because sometimes change in character means. But generally, whenever there's a change in character, you have to ask, how come if it's migraine, suddenly the headache feels different? Okay. So we had 3 red flags. 3 red flags. Okay. So then we asked for patient comorbidity. And then because our questionnaire has got 1, 2, 3, right? So the third one is patient comorbidity. Then we went through her NEHR. In the NEHR, we realized that actually she is a lupus patient on follow-up by rheumatology, but only in the last few months. Because before that, she was followed up by KK rheumatologist, and only at the age of 17 or 18, they transferred her to us. Since transfer, she's been seen by the renal physicians as well as the rheumatologists, and they're struggling to control a CKD. Hypertension is also out of control, and they are upping steroids and immunosuppressants. Now, with this, you have to start thinking. The fact, if she had a benign patient profile, let's say she's got no problem at all, she's just an average 21-year-old lady. Now, the way you will approach these 2 symptoms will be different from if you know that she has got lupus, she's on steroids, which means she's immunosuppressed. Therefore, she may not mount a fever. She's got renal disease and hypertension, which means she can get hypertension-related complications like bleeds. She's also procoagulant, so she can get cerebral venous thrombosis. So the pre-test probability of secondary headaches increases because of a patient profile, right? So this is what we did. We took the headache profile, hers is migraine. We had 2 + 1 red flags for her. One was obtundation of sensorium, change in character, and low-grade fever. Patient profile, very sinister. Lupus, hypertension, steroids, immunosuppressants. So we started thinking, what could she have that can explain this? Well, we thought about a few possibilities. Because she's got lupus and hypertension is out of control, we thought maybe this is like hypertensive crisis. Hypertensive crisis, another term for it is posterior reversible encephalopathy syndrome. Okay, basically, it is severe hypertension causing edema in the brain. Because she's got lupus and she's got nephrotic syndrome, she's procoagulant, right? So she can develop CVT. And CVT, you can have severe headache and loss of consciousness. So we thought these two are possibility. Meningitis, we thought also possible because she's on immunosuppressants. So when you're on immunosuppressants, maybe the fever will not be so severe. So 37.6 is already a good enough sign for her. So we thought these two are possibilities, 1, 2, and 3. Intracranial bleed is possible, but when we examined her, there was no focal signs or symptoms. So we thought low down. So this is moderate possibility. These three were moderate possibility and intracranial bleed was low possibility. So when it is low possibility, then you don't need to do too many investigations, right? But if it's moderate possibility, then you need to do an investigation that is fairly specific and sensitive. So because we thought that the cerebrovenous thrombosis and press were at least moderate possibility, the CT scan that the A&E has done and said CT scan is normal and left in the observation room, we said not enough because she's moderate possibility. Moderate possibility means you need a more sophisticated investigation. So we said she needs a MRI and MRV. So we ordered a MRI and MRV. But then meningitis, we said it's moderate to low probability. It's lower down, number 3, right? Because although that she had reported temperature the day before, in the emergency department, no fever, no neck stiffness. She looks otherwise very well. You know, her total Y was also normal. So we thought, okay, low probability, but never mind. We do the ESR and CRP. So because the probability of meningitis is not very high, we ordered a test that is of low and moderate probability. If let's say, if I had examined her and I found her neck was very stiff, she had very high fever, you know, and she was looking very drowsy, then no point wasting time with ESR CRP. What do I need? I need a spinal tap. Okay, so always choose a test. The test chosen is predicated on the pre-test probability. So here, MRI, MRV was high. Cerebrovenous thrombosis and press was high on the card, so we ordered MRI, MRV. And because the chance of meningitis was moderate, we just do this. And then, as we went on to see the next patient, because emergency department, this is the normal days before COVID, right? So there are like thousands of patients you have to see, right? So as we went to the next patient, then about half an hour, 45 minutes later, the results came out. CRP ESR was high. So immediately we said, hey, CRP ESR is high. So the pre-test probability of meningitis go to moderate, but because this is high, we cannot ignore it. So we quickly started antibiotics, ceftriaxone, vancomycin, and ampicillin, okay, which is the meningitis doses, right? And then we said, okay, we better do a spinal tap when she gets admitted to the ward. But we're still waiting for the MRI and MRV. So we finished clucking, Emma and I finished all the clucking, then we went home, right? We passed over to the on-call registrar. On-call registrar called me 5 hours later when the MRI, MRV was done. And what it shows firstly, severe vascular pathology, okay, and multiple infarcts. And the diagnosis was vasculitis. So actually, in retrospect, we didn't consider CNS vasculitis because lupus, you can get vasculitis, right? We didn't consider CNS vasculitis, you know. But luckily, we got away with it because we had a formula. The formula wasn't too far off. Okay, saved our license and saved the patient's life. But we did the right scan and the scan showed vasculitis. So we immediately started the patient on steroids at midnight. Next morning, we called the rheumatologist. They came in, converted her to cyclophosphamide, and then subsequently she did okay. So the point is, this was some of the things that were written in the notes before we went to see the patient. You know, so the 2+2 part of the brain that says patient looks well, probably migraine because she has migraine. Let's treat with some analgesics and observe. Okay, let's get a plain CT scan because that is the easiest first line test. But if you think about it, easiest test means is it the best test? And how do you know what is the best test? The best test is determined by two things. One is your differential diagnosis, and one is your pre-test probability, your index of suspicion. The index of suspicion is high, you choose the most sophisticated or most specific test. If your index of suspicion is low, you can screen. In this case, infection was low, and true enough, she didn't have an infection. CRP PSR was actually due to vasculitis. Okay, so but you can screen with a simple test. So that is the lesson we learned from here. So in summary, okay, so now it's 12:38. Okay, in summary, whenever you see a migraine patient, whenever you see a headache patient, always ask yourself 3 questions, and you can clock the patient within 10 minutes and move on. Okay, you don't need to hang around too long. Okay, and you are more likely than not get consistently correct answers. Okay, go through the headache profile very quickly. Okay, in the background previously, and they often will deny that they had headaches in the past. In Singapore English and Singlish, migraine, the term for migraine is normal headache. Okay, so don't be put off by this term normal headache. Okay, firstly, there's no such thing as a normal headache. Anybody who has got recurrent headaches that require analgesics, time off from work, anything that comes again and again, there must be a primary headache syndrome. The problem is that the community doctors, okay, because headache is so poorly taught in medical school, the community doctors just dismiss, oh, you got normal headaches. But actually what they mean is migraine. And migraine is so common. Okay, 30% of the normal population is supposed to have migraine. So be careful when you say, oh, there's no primary headache syndrome. Because if you don't have a primary headache syndrome, then your index suspicion for secondary headache goes up, you see, just like what I said earlier. If the person never had asthma before and the person is wheezing in front of you, oh my God, you have to panic a bit, right? But if you know it's a known asthmatic, okay, of course you'll still treat the wheezing carefully, but you at least not worried about the etiology. Okay, so remember to go through this, and then remember to put the context in patient's profile. The patient has got diabetes. What does that mean? The patient has got tuberculosis in the past. What does it mean? The patient has got carcinoma of the kidney, just undergoing chemotherapy, now comes for headache. What does it mean? Okay, doesn't mean that just because he's got carcinoma of the kidney means that you will always have match to the brain. He could have exacerbation of his migraine because he's stressed out. Correct? So therefore, this approach allows you to put everything together and make a judgment. Now, one last point I want to make before I leave this topic is, do you notice that so far I haven't talked about psychosomatic factors at all? Psychosomatic factors, the fact that the person is depressed, the fact that the person is stressed. Why? Because psychosomatic factors do not make the headache primary or secondary. They don't. It is a bias. Bias means what? Systematic error. It's a bias among us. Just because somebody is stressed doesn't make the patient's headache migrate. Now, if you have meningitis and you're on call tomorrow and you have to come to the emergency department, you'll be stressed because you have to call the on-call, you have to call your in-charge person and say, hey, please find somebody else to cover me. Then the person will curse and swear. Then once you recover from meningitis, you'll have every other day call for the next 1 week. So you'll be super stressed. So if the doctor was to ask you, hey, are you stressed? And you say, yeah, I'm stressed. Does that make the headache migraine? No, it's still meningitis. So be careful. Don't take psychosomatic factors. The person is an alcoholic. The person has got drug abuse before. The person is a divorcee. The person is a stressed out person. The person is a psychiatric patient. All these things do not come into the diagnostic algorithm. They don't. But do you take a social history? Do you take a psychological history? Yes. Why do you take it? Because it comes under management. Because if your primary headache syndrome, eventually, after you've done all this, you come up with a diagnosis of tension headache. You come up with a diagnosis of tension headache. Or you come up with a diagnosis of transform migraine or uncontrolled migraine. Then we know these two conditions are almost always associated and exacerbated by stresses. So for you to manage these headaches well, it's not just pushing medicines. You have to manage their psychological factors. So psychosomatic factors come in the management stage, not in the diagnostic stage. So a lot of errors come in later on as in subsequent tutorials. I'll be giving you more case scenarios, okay, like this case further on, which is one of my mistakes, okay, where you illustrate some of these mistakes, okay. But I'm going to stop now because it's 12:40 already. Just so that whenever you watch American serial and all that, they will make sure that you come back for the next episode, right? So to make sure that you come back for the next episode, okay. So the next episode of our tutorial, we'll be talking about the 4-question approach to dizziness, okay? 4-question approach to dizziness. So what are the 4 questions? Well, do you have vertigo or non-vertigo? Number 2, is it associated with central features or not? Number 3, is this the first episode or not? And number 4, how long does it last? Okay. But if you want to know more about it, you have to come for the next tutorial. Okay. With that trailer, I'm going to stop now and allow you to ask questions. Otherwise, we are completely aware that that you guys are busy, so we'll keep each tutorial short. The only thing I request from you is, I promise I will never keep you waiting. I don't try to do that to people. I'm always on time. I've got this thing about fetish about time. So I expect you guys not to be late also. So if you keep your side of the bargain, I'll keep my side of the bargain. And I will not hold you back longer than time necessary. In fact, I try to release you earlier so you can get back to your work or go to sleep, as the case of people like Waisan wants to go and sleep. Okay, bye. Oh, no, actually I have to wait for a while for questions. Any questions? I have to unmute you all to... Okay, so you can unmute yourself and ask questions if you have questions. If you have no questions, you can leave. I'll wait for another 5 minutes. And then Keegan will distribute out the notes over the next few days, because there was some problem with the link that I sent him earlier. Okay, no, don't feel paiseh, no? If you have nothing to ask, you can leave now. Bye-bye. Keegan, you can leave also, don't worry. I'll just wait another 2 minutes in case there are people asking questions, and then I'm going to leave soon.